Good evening, everybody, and welcome to the first I'm Not Done Yet initiatives update. Obviously, this is an incredibly challenging time, now compounded by the fact that many of us, at least in the Northeast and up the East Coast, have been subjected to a hurricane. We have our power out. It's a little dark here. You can tell the air conditioning's off, so I apologize if we're showing a little heat. Anyway, this is a great opportunity for us to bring you up to speed on what we're up to. And really, the purpose of tonight is really two things. The first thing is to thank all of our friends and family who have been so gracious with their support, who have really embraced our mission, really Bobby's mission in serving the interests of the adolescent young adult, unique challenges of the adolescent young adult population. And just being there with us. And I really want to give a big shout out to the Duke community, Bobby's friends from Duke and the Pike fraternity who have been so instrumental in keeping his legacy not only alive but flourishing among the Duke faithful. So thank you very much for that. The second reason tonight is really, really important is that we, Liz and I, are passionate about making sure as stewards of the gracious and generous financial support that many of you, most of you have provided, is done in a way that demonstrates progress, demonstrates the fulfillment or the intent associated with the mission of the foundation, and it's just really important to us to ensure that that we're aligned. And that hopefully you're as excited as we are about the path we're on and the progress we're making. So tonight, we are really, really lucky to be able to showcase the work we're doing with the folks at Duke, the teen and adolescent oncology team specifically. A couple of the programs you're going to hear about tonight, actually Bobby was involved with during his time at Duke. As many of you, I'm sure, have recognized through our newsletters and our posts, Bobby loved Duke, and the level of connectivity and passion for that environment and the way they cared for him, frankly, during the final diagnosis and the treatment that they provided was unbelievable. But it also allowed him to connect in a unique way there, and connect in a way that allowed him to be a catalyst for some of the things you're going to hear about. So. As a reminder, let me take a step back. As a reminder, the I'm Not Done Yet Foundation was started almost 3 years ago now for the sole purpose of advancing services, research, initiatives for those unique and frankly, sometimes invisible challenges that affect adolescent young adult cancer patients. And so, again, we're thrilled to have everybody join us tonight. And with that, why don't I turn it over to Coleman, who is going to serve as the host for tonight's discussion. Coleman, thank you.
Thank you, Peter and Liz. As Peter mentioned, I have the privilege of managing the Duke Teen and Young Adult Oncology Program, otherwise known as the TYAO program at Duke Cancer Institute. And you're going to hear a lot of TYAO tonight. Our Patient Advisory Council at Duke recommended this wording and is what we use today for our program. But please keep in mind, TYAO is essentially the same thing as AYA, which means adolescent and young adult. And these are often used interchangeably when referring to this population. The Duke TYAO program helps to provide age-appropriate services for oncology patients between the ages of 15 to 29. Includes a comprehensive approach, which you will get to hear more about today during the panel discussion. The I'm Not Done Yet Foundation has been a valuable partner. We have worked together to develop a strategic plan that has fostered program growth and has resulted in building a successful model for other medical centers to adopt. We will continue our collaboration to meet the unique needs of this patient population, as Peter said. And if you would like to learn more about the Duke Cancer Institute's TYAO program, we encourage you to visit our newly renovated website that we're super excited about at dukecancerinstitute.org/TYAO. The website's designed specifically for easy navigation of resources and services for our teens and young adults as well as their loved ones. So before we proceed with our agenda, I'd like to make a couple of housekeeping announcements. Today's event will be recorded, and if you have a question you would like to ask, please select the Q&A box at the bottom of your screen to share. We will do our best to answer during our Q&A portion later on after the speakers have presented. So I now have the pleasure of introducing our speakers. So first, Dr. Lars Wagner. He is a pediatric oncologist and the chief of the Division of Hematology Oncology. Dr. Wagner has a, hold on. There we go. Dr. Wagner has a clinical and research focus on the care of adolescents and young adults with sarcoma. He has led multiple institutional and national clinical trials exploring new therapies for patients with recurrent sarcoma, and has an interest in new drug development and identification of predictive biomarkers. Additionally, he is the physician champion for our TYAO program. So unfortunately, Dr. Cheyenne Corbett was unable to join us tonight, but we are fortunate to have Dr. Caroline Dorfman with us in her absence. Dr. Dorfman is an assistant professor of psychiatry and behavioral sciences. Dr. Dorfman is a clinical psychologist who has been providing clinical care to patients at the Duke Cancer Institute for the last 6 years. She currently serves as the lead clinical psychologist for our Duke Teen Young Adult Oncology program, and her research focuses on improving symptom management for survivors of young adult cancers. Next, we have Dr. Gary Maslow, who is an assistant professor of psychiatry and behavioral sciences. Dr. Maslow is also the medical director for child psychiatry services, Duke Cancer Institute psychiatry services, and integrated mental health programs. Additionally, he is the co-chief of the Division of Child, Family, and Community Mental Health with the Department of Psychiatry and Behavioral Services. And for the past 20 years, Dr. Maslow has been involved in developing peer support programs for youth with chronic illness, including a program now at Duke called Adolescents Transitioning to Leadership and Success, otherwise known as ATLAS. Dr. Maclean Pollock is an assistant professor of psychiatry and behavioral sciences. Dr. Pollock is a licensed clinical social worker and researcher in public health with a focus on maternal and child health and epidemiology. She's the director of peer coaching programs at Duke and has a strong interest in peer support interventions to facilitate growth and connection for adolescents and young adults with chronic conditions, as well as their families and providers who care for them. And she will be available to answer questions during the question and answer portion later on after at the end of the discussion. And then finally, we have Dr. Kelly Acharya. She's an assistant professor of obstetrics and gynecology. Dr. Acharya is a reproductive endocrinology and infertility specialist and the director of the Duke Fertility Preservation program. She's also the co-lead of the Duke Onco-fertility steering committee. Dr. Acharya has a strong interest in evidence-based medicine and in using the most up-to-date methods to provide an individualized care for each of our patients. So, Dr. Wagner, we will start with you. Teen and young adult oncology patients are a unique population. Could you share from a medical standpoint why services and a dedicated program are needed for this population?
Sure, and thank you, Coleman, and thanks to Peter and Liz and everyone that's involved with this wonderful organization. This is great to be able to speak with you tonight. What I was hoping to do is to provide a brief overview of our program, the Teen and Young Adult Oncology program here at Duke, and talk specifically why it's important that we have a program for these patients between 15 and 29 years of age. And I've got 4 15 to 29-year-olds in my family right now, and so it is a unique time in life for sure. We know that there are some types of cancers that occur just in little kids and some types of cancers that occur in older people, but many cancer types kind of span both pediatrics and adults. They don't cap off neatly at 18 or 21 years of age. So cancers like sarcoma or leukemia or lymphoma, these fall typically, some go to pediatrics and some go to adults, but these are real important diseases in which we need to have intentional and direct efforts for their care. And we need to do this because just about everything about TYA patients is different from the typical pediatric patient and the typical older adult with cancer. For example, the biology of the disease is different. The different types of mutations that are present in the tumors or the way that they respond to therapies can be different than the way the little kids do and the way older adults do. Certainly the psychosocial issues are completely different than what we see in pediatrics, and what may be the big issues for older adults tend to be quite different for the TYA population. TYA patients can have particular concerns regarding access to care. Many of these patients are in the process of leaving the nuclear family and getting out on their own. And so there can be insurance issues or transportation issues or other things that affect access to care. And then figuring out what's important for these patients and what are the biggest issues: diet, exercise, nutrition, and especially late effects of treatment like fertility or other long-term complications. Next slide, please. If you can advance, there we go. And so in looking at the one slide previously where it says the numbers, there we go. So if you think about the logistics and the numbers of TYA cancer, first of all, cancer is the leading cause of death by disease, both for children as well as the TYA population. So it's a really important medical problem. We know that patients between the ages of 15 to 29 make up about a fourth of a pediatric oncology practice, but only about 5% of an adult oncology practice. And this is one reason, because of that relative higher proportion of patients, that pediatric oncologists are so invested in the success of programs like this. Statistically, about 60% of TYA patients are over 20 years of age and 40% are less than 20 years of age. And at Duke, we currently treat about 300 new patients a year in this age range. And while we want to treat these patients in a comprehensive setting and provide all the services that they need, the reality is that about 80% of TYA patients across the country are actually treated by community oncologists outside of an academic center. And so one of our missions is to reach out to our regional colleagues and places around the state that are seeing these patients and trying to get access for these patients to a more comprehensive care center. Next slide, please. So as we think about one important difference in how TYA patients are different, and that is the outcomes. We know that outcomes have been worse for TYA patients for many diseases when we compare them against younger children. And unfortunately, these poor outcomes have remained very stagnant over the decades when you compare them to other age groups. Next slide, please. And you can see in this graph here that the progress that has been seen, for example, with leukemia in other age groups, in younger kids and early teenagers, has not been realized in the patients between 15 and 24 years of age in this group. So we're just not making the same level of progress that we are in younger children or even in older adults. Next slide, please. There are likely several reasons why we're not making progress. As I mentioned, there's differences in tumor biology that we need to understand better, but there's also some non-medical reasons that impact this. Poor compliance or poor tolerance of therapy or willingness or ability to put up with the complications of therapy. There can be issues with access to healthcare, delays in diagnosis. And then, as I mentioned, a lack of familiarity for some community oncologists in treating the special needs of this particular population. There's often inconsistent treatment approaches that are applied. And then a key reason for the worse outcomes and the failure to make progress has been the low rate of involvement in clinical trials. If we keep doing the same thing over and over and over again without making changes, we're unlikely to see any differences. And unfortunately, that's played out again time and time for the TYA population, where they're not getting involved in clinical trials and can develop new advances in therapy. Next slide, please. So the Duke TYA program is designed to try to address all of these issues, and starting here at the top circle with the access to clinical trials. One thing I've been directly involved with is trying to open up trials that cross the adult and pediatric spectrum to specifically target this patient population. We need trials of new therapies that are a little bit different than what's being used in little kids and different what's being used in adults. We also need to understand the biology of these diseases even better. And so we have a variety of therapeutic and translational research trials that we're opening to try to learn more from each patient that we care for. We also are in the process of developing some robust psychosocial support mechanisms for these patients. Their needs are different and their issues are different, and we need somebody that can relate to them in an age-appropriate way that can really provide the psychosocial support that is so critical to allow treatment to continue and reach its completion, and to provide them support in a more comprehensive way than just providing chemotherapy. I'm very happy to talk about the progress that's been made, in particular with Onco-fertility, and all the efforts at Duke here most recently is we're banding together and developing more comprehensive strategies to provide fertility preservation measures for our patients that are undergoing therapies that have a high likelihood of impairing later fertility. We need to be planning for success and ensuring that we're doing everything that we can to make a life after therapy as fulfilling as we can for patients. And so the Onco-fertility measures are real important with that. And then just facilitating access to care and doing everything we can to reduce barriers, improving transportation and other ways of getting access to these patients, so they can receive all the benefit from a comprehensive cancer center. And then finally, after treatment is done, making sure we have programs put in place to deal with survivorship issues and maintaining their health long term. Next slide, please. So those are just a brief overview of the things that we're trying to accomplish and why teen and young adults are different, and the intentional efforts that we're trying to take at Duke to really target this population and maximize the care that they receive here. So I'll toss it back to Coleman. Thank you for your attention. I'll be available to take any questions afterwards. Thank you.
All right, thank you, Dr. Wagner. So we also need to care for the person as a whole for the best possible health outcomes. We can provide the medical care, the treatment, but we also must focus on the psychosocial needs that accompany a life-altering diagnosis of cancer. Dr. Dorfman, talk to us more about what we are doing to address the psychosocial needs of this population.
Thank you so much for the opportunity to talk to you all tonight. I feel very fortunate to be here and to be able to share with you a little bit about what we are doing here at Duke to address the psychosocial needs of this unique patient population. So first, I just want to tell you a little bit about where our TYAO program is housed here at Duke. So it's housed within our Supportive Care and Survivorship Center. The Supportive Care and Survivorship Center has a lot of different programming that provide clinical services, and each has its own program of research and also provides education and training. And so just to give you an idea of where we fit within the larger program, Additionally, I wanted to point out one other program within our Supportive Care and Survivorship Center, the Duke Cancer Patient Support Program, which provides psychosocial services at no cost to patients at Duke. And these services include things like medical family therapy, child life services, psychology services. And I'll talk a little bit more about how this fits in with our TYAO program, but importantly, our teens and young adults have access to these services as well. So I know that Dr. Wagner alluded to the unique psychosocial needs of teen and young adult patients, but one of the things that we thought was really important is, while our Supportive Care and Survivorship Center is multifaceted, we needed to have a designated program for our teen and young adults because of their unique needs. This is a particularly vulnerable population of patients who have needs that may not be addressed as specifically as maybe a younger patient's needs or an older patient's are. And so in this way, they sometimes fall through the cracks of the system. And so we wanted to have a designated program to address their needs. So in thinking about who we serve here at Duke, this figure shows the number of teen and young adult oncology patients seen here at Duke since 2015, so between 2015 and 2019. And overall, we had about 1,000 patients seen. But one of the things that's quite striking, if you look at this figure, is the number of disease types that this represents. And what you also can see is that in some disease types, it represents just a handful of patients. And so what this means is maybe their care teams may not be as familiar with the unique needs that come up for a patient in this age range. And also what it means is that these patients are coming to clinic and maybe not seeing another young patient during a clinic visit. And so for some patients, this can be quite isolating, and it can also create a disparity in the kinds of services that they may have access to. So in thinking about this population, it's really important to think about the context in which they're diagnosed. So these individuals are diagnosed at a time when they're really having some important developmental milestones occurring. So one is that maybe they're working to complete their education, or maybe they're working to complete an advanced degree. They're also working to establish their independence from their families of origin. It could be the first time that they're living on their own. They might be working to establish their financial independence as well, where now they're in their first jobs and they're trying to climb the ladder within their career. And additionally, this is a time when they're building peer and romantic relationships. They're dating, they might be getting engaged or getting married. And then for some patients, they might be thinking about starting a family or building their families. So there's a lot happening at the time of diagnosis. And so what ends up occurring is that after diagnosis, there are significant life disruptions for these patients in a variety of different domains. So one of the things that you can see in this figure, this is a figure from the Institute of Medicine, is that the disruptions happen in most areas of people's lives that are really quite important to them. So disruptions in their plans for the future, disruptions in how they view themselves and their body, disruptions in their career and education, like I mentioned before, disruptions in their peer relationships as they see peers continue on working towards goals that maybe they've had to put on pause, or maybe are now having to think about altering or changing because of their diagnosis and treatment. And so what ends up happening is that patients present with some pretty significant psychosocial concerns across a variety of different domains. So in the psychological domain, we might see depressive disorders or anxiety disorders or fears of recurrence. And for some, we might even see post-traumatic stress symptoms. When we think about the physical domain, we see, like I mentioned before, body image concerns. Some patients might have experienced weight loss or weight gain. And additionally, there might be changes to their fertility or sexual functioning that could be quite distressing. Additionally, we think about the social domain. So like I mentioned before, peer and family relationships could be impacted. And also there are high rates of feelings of isolation when an individual might see that there aren't that many people when they come to treatment that look like them in a treatment area. But additionally, their friends might not get it in the same way that another young patient might understand their experience. We also see concerns related to educational and vocational attainment, specifically those associated with cognitive functioning following different kinds of treatments. Patients might experience memory challenges, difficulties with concentration as well as attention. And then also, like Dr. Wagner mentioned, there are concerns related to health behaviors, including things like engaging in recommended physical activity and diet, substance use, and also smoking behaviors. So one way that we have been working to address these psychosocial concerns is by having a designated patient navigator for our TYAO program. And we are one of only a handful of programs in the United States that has a designated patient navigator for their TYA program. And this individual, her name is Shannon, she's absolutely fantastic. She helps patients to receive referrals for different services to address these psychosocial needs. So for example, Onco-fertility, peer coaching, cognitive screening, our peer activity groups and community outings. She helps to get patients connected with recreation therapy and psychology services. And importantly, she helps to get them connected with our designated medical family therapist for the teen and young adult program. So just to share with you what happens for a patient when they are identified who fall in this age range is they're identified by a few different sources, and these are the ways in which they get to our patient navigator. So first, they might be identified by a new patient coordinator because they have a newly scheduled appointment. They might be referred to us from a member of the oncology team or from social work. They might be referred to us from the medical family therapist, but also our navigator reviews the reports of hospitalized patients. And then from there, she will work to coordinate and provide education for the patient to help address some of these barriers. So she'll facilitate referrals to services and resources, especially those that will address their developmental needs. And these services may be both within Duke or outside of Duke. One service in particular that I'll just highlight here is Onco-fertility. So if a patient expresses interest in fertility preservation, she will provide education and resources on Onco-fertility and help to facilitate rapid referrals to our Duke Fertility Clinic. And also importantly, she will provide patients with additional resources if needed. We'll provide patients with things like information about financial assistance programs to help offset the costs. And finally, the role of the navigator is not just for those who are newly diagnosed. Our navigator follows patients throughout their care at Duke into survivorship, providing unique TYO services. Additionally, our navigator will provide referrals to the cancer patient support program services that I mentioned before. Things like if a patient has young children, they may be referred to child life services for assistance. And then additionally, we have our clinical services, but within our program, we also have research initiatives and work to provide training. So for example, our research initiative that we have going on is having participants complete self-report questionnaires so that we can better understand their unique needs, so we can adjust our programming to meet those needs. And additionally, with regard to training, we have been involved in helping to train providers and staff here at Duke about the unique needs of teens and young adults, and also been involved in the North Carolina AYA Symposium, which was unfortunately postponed this year, but will be hosted by Duke next year. Then finally, I just wanted to end by providing some metrics about our navigation program. So since February of 2020 and up until July 8th, 2020, our navigator has served 81 unique patients for a total of 262 patient encounters. And of these encounters, we have seen over 100 referrals being placed to different services through Duke. So with that, I will pass things over to Coleman.
All right, thank you, Dr. Dorfman. We're truly offering some unique roles. So let's talk a little bit more about peer connection. And Dr. Maslow, peer connection is the common thread we hear among our teen and young adult population. Tell us more about what you are doing to address this need.
So hopefully you can see me now, and I'm on mic. Sorry for the delay. I have two different views, so okay, now I can see. So anyway, thank you for the opportunity. Sorry for that slight technical difficulty. It's really an honor to be able to speak with you today, and to be able to talk about the work of what we call Bobby's Coaches and the partnerships we have across Duke Cancer Institute and across Duke. I'm a child psychiatrist and a pediatrician, and have a lot of experience working with kids with cancer, and it's been a really wonderful partnership, and I think this opportunity to speak kind of highlights that. I'm also incredibly grateful to Peter and Liz for the opportunity to speak, and the whole Menges family. As we talk about Bobby's Coaches and this work, it really has been a partnership and thinking about how to deliver peer support and coaching for young adult cancer survivors and their parents. And I think Liz and Peter have also encouraged us to think about and expand our work to patients who have other conditions. It is a interesting moment for me personally to be talking with you about young adult cancer. In some ways, just because of the date. About 18 years ago, my wife actually was diagnosed with cancer and is now 18 years as a survivor. So she wasn't my wife at that time, but a friend from college. And it was actually, I was a medical student, and I was sailing on this boat here in Boston Harbor. So I know there's a lot of New Yorkers. I'm a New Yorker, but this is a Boston picture. And so I was sailing on this boat in Boston Harbor on a trip for AYA cancer patients, and here's a picture of a group of patients, young adults with cancer. And Island of Hope was basically where you go out on an hour-bound trip with cancer survivors, and I was a medical student, kind of helping them. And they would go out for 10 days and really learn about each other, about how to move on and become strong in their survivorship. And it's kind of extraordinary. I got off that boat and I got a message. I didn't have a cell phone, didn't have anything like that, 18 years ago, to give my now wife a call, and found out that she had cancer. And I shortly after flew down, and she was 22, I think, at the time. And the thing that helped her, and I think helped me as someone who was in some ways a caregiver for her, was peer support. And I think it was, she was 21, 22, going to the cancer suite and having the patient next to her talking about some aspect of their lives. And I think even I obviously was in medical school and interested in AYA cancer before this experience, but that has continued to be a real motivator for me, seeing what the peer piece, what it means for this group of 10 to 12 young adults with all sorts of different cancers to be able to be together and learn from each other and support each other. So that's kind of my personal background. And just today, it's just a strange day to be talking with you about this, just because of that anniversary. So in that spirit, and I personally and our team has been thinking very much about how do we help young adults. And so I wanted to share with you why we call this program Bobby's Coaches and what it is. Bobby was a mentor in Atlas, which is one of the programs that was mentioned. And it's a group mentoring program, and we hold prom and conferences, and Bobby was a mentor in that program. And what was really remarkable in working with Bobby and having him as a leader in that program was the way he actually not only just was a peer, but he was a coach. And there one quote from one young man who said, "Bobby encouraged me to take up the guitar after my illness made it impossible for me to play the saxophone." And many other people described similar experiences where Bobby, as a mentor, as a peer, was able to help them find a path through their illness to find something else. And I think that's our hope for Bobby's Coaches, is to help people find mentorship and coaching that will allow them to move through their survivorship and be able to thrive with their chronic condition. The Atlas program also supports parents. There's a parent group. And then speaking with Liz and Peter, we confirmed there really is a need to provide support for both youth and their parents. So Bobby's Coaches is basically the clinical program that is a part of a larger peer coaching team that we have. And we have 4 programs under our Vocational umbrella, which is peer coaching for activated self-management optimization. But basically, we have an NIH-funded study that is ongoing right now that has recruited about 45 patients it started in January. During COVID, we've already have 45 patients, about 40 or 30 getting coached as part of the study, an inflammatory bowel disease study, a congenital heart disease study. And then Bobby's Coaches is a clinical program that was started specifically to take what we're doing in the research setting and begin to try to do it in a clinical setting that isn't a research setting. The main theory is that AYA, so TYAO, or adolescents, young adults, they have innate adaptive ability that we can build on. And so our goal is to help them become activated and engaged, and then take that engagement and apply it to self-management. And ultimately, you'll have a young adult who has skills and is activated to use those skills, and then can navigate as many as Carolyn and as Dr. Dorf and Dr. Wagner were speaking about, can navigate these complex medical and psychosocial transitions, but we really have to help them be able to lead that charge. And the goal is also to decrease parental distress and support them in letting go and helping their children be independent. Basically, we work with a company called Inquisit Health that's actually based out of New Jersey. I think there's some folks from New Jersey there. And Inquisit Health basically has a mentoring platform by which you can, mentees and mentors can text. It facilitates secure HIPAA-compliant calls. And so basically, the mentoring program, we match people, a young adult with chronic condition, with a coach who's been trained in basically a health coaching paradigm, and they can speak weekly, every other week, and kind of work towards different goals, whether it's becoming a leader of their own condition, managing their condition, identifying future goals. But it's basically a HIPAA-compliant, secure system that allows for that. This is just a brief timeline, but I think I have to say that the coaching program has really grown as a result of the guidance and support from the I'm Not Done Yet Foundation. I think we had a research idea, and I think working with Peter and Liz to really go from, let's just have this research idea, how do we actually start doing it now? And at this time we have patients in all these different studies and have I think probably 7 cancer patients total across the studies, and the Bobby's Coaches that are getting the coaching intervention right now. So just briefly, the program also benefits the coaches. So this is just a picture of some of our coaches. I think one of the quotes I like is, each time I go through the coaching process with a participant, it feels like I'm going through it. I feel I've become more confident on the outside by coaching. And so it benefits the young adults who are coaches. There's this idea of something finally clicking where the coach can really help the young adult. And these are just a few quotes, I think, that summarize the value that participants had in interviews. And I think I'll just read one of them, just given the time. But this shared experience one, he was just, I can't even explain it in words completely, but just, he was also a fellow Hodgkin survivor. So just kind of having that connection and just having someone there, he was very encouraging, and that was very meaningful to me. And I think that idea of having a young adult coach who themselves has been through the experience of cancer or through another condition is really, really a powerful thing that can help lead to change. And we, at this point, the Bobby's Coaches is focused on oncology, but I think our hope is really, and through our research as well, to expand that to young adults with a range of different conditions and their caregivers and parents. And again, that's, I think, the support of the I'm Not Done Yet Foundation has been instrumental in kind of helping us move in that direction. Our hope is to continue doing this at Duke for our Duke patients in North Carolina, but it is something that we really see as having the potential to be disseminated for patients and young adults pretty widely. So thank you for your time, and I'll pass it back to Coleman.
Thank you, Dr. Maslow. Dr. Acharya, our teen young adult oncology population is often diagnosed with cancer and then either unaware that some cancer treatments can lead to infertility, or they are immediately hit with having to make a decision about preserving their fertility. Could you talk to us further about fertility preservation, or as we call it, onco-fertility?
Sure. Thank you, Coleman. And thank you so much to all of you for having me here for this discussion. It's really my honor to be a part of this team and this initiative at Duke. So I will share my screen. Okay. So when a young person has just been diagnosed with cancer, they have so many things running through their mind. And one thing that they may not have considered is how their cancer treatment might affect their fertility or their ability to have children in the future. And we know that certain cancer treatments like chemotherapy and radiation can possibly decrease someone's ability to have a child in the future. And this is because the reproductive tissue, so eggs in women and sperm in men, are vulnerable to chemotherapy and radiation. So let's take, for example, a young woman diagnosed with cancer. Girls are born with all of the eggs that they're ever going to have. So even though most women mature and release an egg each month, we can't actually make more eggs once they're gone. So this woman starts out her cancer treatment with tens of thousands to hundreds of thousands of eggs in her ovaries. But the life-saving cancer treatment could actually decrease her supply of eggs, so much so that after treatment, she is in premature ovarian failure or premature menopause. And if this happens, she may not naturally get periods on her own in the future, and she may not be able to naturally get pregnant and have a baby. And the same thing could obviously happen to a young man diagnosed with cancer. So after the treatment, he may be left with either no sperm or a very low supply of sperm and have trouble fathering a pregnancy in the future. So fertility preservation or onco-fertility is treatment to preserve or save someone's reproductive tissue, just in case that person's fertility is affected by their cancer treatment. So when a patient, the patient's family, or the patient's oncology team identifies the need for an onco-fertility consultation, they reach out to the TYAO team and they connect the patient to the fertility preservation specialists. And the first step of the onco-fertility consultation is typically a risk assessment. So a fertility specialist reviews the patient's age, sex, what cancer treatment they're going to be receiving, and we then generally will let the patient and their family know if the patient's at low, intermediate, or highly increased risk to their fertility after cancer treatment. We then discuss what options are available for fertility preservation or to protect their fertility for the future. So for girls or women, fertility preservation could include freezing of eggs, fertilized eggs or embryos, or doing a surgery to remove and freeze ovary tissue before cancer treatment. For boys or men, fertility preservation mostly includes freezing of sperm. And depending on the fertility preservation technique that's best for the individual, this could take a day or two, like in the case of sperm freezing and injection or ovarian tissue cryopreservation. Or it could take up to a couple of weeks, like in the case of egg freezing, in which we need 10 days for injections, and then the egg harvesting procedure itself. So the fertility specialist typically works with the oncologist to determine which options are available to each patient and which option would be deemed safe in their particular situation. So another frequently asked question is what to expect in terms of out-of-pocket costs for these procedures. So for egg freezing, the total cost was previously around $7,000. However, one of our early successes in our onco-fertility program was to consistently get this cost down to about $4,500 for most patients. But you can see that this is still a huge cost to incur, especially for a young patient, for an adolescent or a young adult. And we also typically do help the patient apply for programs like Livestrong, Heartbeat, or philanthropic funding that can help cover the cost of the procedures, the cost of medications, or storage and transport fees. For sperm freezing or semen cryopreservation, this typically involves one or more visits for sperm collection, which costs approximately $300 per collection. And in addition, there are some storage and transport fees. And it is important to mention that this is per collection. And so for a young man that's at highly increased risk of fertility loss with his cancer treatment, he may be recommended to collect sperm multiple times to have enough sperm there to give him a good chance of being able to create a pregnancy with that sperm later. And then it's important to know that philanthropic funding or financial assistance may be an option, and our TYAO team, as you've heard, really helps to facilitate applying for that funding for our patients. And as you might imagine, this is especially important because these costs are high, and this comes at such a vulnerable time in our patients' lives, both medically and financially. And so anything we can do to help them achieve fertility preservation at a reasonable cost is great. So with that, I'll hand it back to you, Coleman.
Thank you, Dr. Acharya. Yeah, so and speaking of kind of philanthropic funding, the I'm Not Done Yet Foundation has not only provided us a generous donation to create a fund for teen young adult oncology patients who are unable to afford fertility preservation, but through the development of this process, patients' comprehensive financial needs are also assessed. And so as a result, they're connected with services such as financial care counseling and social work to establish a long-term picture of their needs. So if patients meet certain financial criteria, we are able to cover up to 50% of the cost of their initial fertility preservation procedure. And it's been a long journey to establish this program, and we're happy to announce that we finally have started allocating funding. And so last week, we were able to provide financial assistance for a patient using the I'm Not Done Yet Foundation funds. And so just to give a brief background of this patient, he's in his mid-20s. He was having to essentially make a decision between spending his money on medication or planning a family in the future. So with the help of the funds from the I'm Not Done Yet Foundation, he was able to successfully undergo sperm cryopreservation. So that's pretty cool. So now we're approaching 6:50, so now we're gonna kind of go into the question and answer portion of the discussion. And I would like to thank our presenters for their time and explanation of the need for specialized teen young adult oncology services and a dedicated program. We have taken a comprehensive dive and want to open the floor to questions for our experts. We will start with a few questions that we received from registration. And from the question and answer queue, but I encourage you to send us questions through the Q&A function at the bottom of your screen. So let me pull these up. So the first question, this is going to be to Dr. Wagner. And the question is, when a teen young adult oncology patient is diagnosed by a medical or adult oncologist, how does that physician dialogue with or connect with the pediatric oncologist for an optimal treatment plan that includes both the pediatric oncologist and the adult oncologist?
So that's a great question, and it's one of the challenges in working in a big institution like Duke, because there are a lot of diseases that affect TYA patients, and there's a lot of physicians on the adult side and pediatric side that help coordinate. Communication is the key. We've been able to do this for several disease groups to start with. For example, sarcoma is a good example. As we sit down together in tumor boards and routinely discuss patient care issues together with the adult oncologist and come up with the best plan for management. To me, it is not as important who manages them, either the pediatric or the adult physician, but is this patient getting access to a clinical trial? Is this patient getting good comprehensive care? Are we addressing the specific TYA needs of the patient? And so we're building those bridges with other specialties. Brain tumors is a good example, where there's a pediatric oncologist now working in the adult brain tumor program and seeing these young adults with brain tumors and providing a pediatric perspective to this as we work together closely with our adult colleagues.
All right, thank you. So we have one for Bobby's coaches. So how do you see Bobby's coaches extending to other populations and beyond Duke? And so we'll direct this one to Dr. Pollock, who's the director of peer coaching.
It's a great question. So there are many different opportunities for expanding the reach of this peer coaching intervention. There are three in particular that I think are worth mentioning. One is what Dr. Maslow already mentioned, which is expanding peer coaching to other youth, other adolescents and young adults with chronic medical conditions. So conditions like lupus, stem cell transplant, diabetes, helping them work on their self-management, taking that on for themselves. The second one would be working with parents of those adolescents and young adults with different chronic medical conditions. We're seeing through the Bobby's Coaches program just how important it is to support the parent during this time as well. And then finally, we would really like to be able to see this intervention expand beyond Duke. So the intervention is provided remotely, as Dr. Maslow was mentioning, with the secure platform. We're converting our training to a remote training, especially during this time of the COVID-19 pandemic. And there's a really great opportunity to be able to expand it across the country to different health care centers and different community agencies.
All right, thank you, Dr. Pollock. The next question is regarding the Onco-fertility program. So since the Onco-fertility program started, what impact have you seen? And we will direct this to Dr. Acharya.
So we've seen a big impact since the Onco-fertility program started. Just as an example, since February of this year, so about 6 months ago, we've had about 45 referrals, and about half of those people have decided to go forward with some form of fertility preservation. Now, if we compare that to the year prior to our Onco-fertility program starting, we had about 50 referrals for that whole year. So if we're just going based on the past 6 months, we've about doubled our volume of referrals. So that's been great. The other thing we've done is just made it a lot easier to place a referral, to get patients in for Onco-fertility consultation. So now there's actually an order that we can put in through the electronic medical record that sends an automatic message to our patient navigator and makes sure that we're not letting people fall through the cracks and that people are getting the fertility preservation counseling that they need.
Thank you, Dr. Acharya. So the next question, which is another great question. So what does the future look like for the Teen Young Adult Oncology program? And we'll let Dr. Dorfman answer this.
So one important component of a program is also ensuring that we are conducting research so that we can better understand our population. And so one component I see in the future is additional research studies through our program. I know that this is a priority area for funding from the National Cancer Institute and the National Institutes of Health. There are lots of new requests for applications that have been put out that our team has been working to respond to. And so that's one area that I see us being able to build new psychosocial support programming through research. I'd like to also see if Dr. Wagner has any thoughts on this question from a medical standpoint.
Yeah, it's a really exciting time, and I think we just need to double down on the several good efforts that have been started. I think we need even more consistent engagement with clinical research. We've got to learn about these diseases more. We've got to come up with better ways of treating them. That's one of my jobs, is to try to get as many studies open as we can so these patients have the opportunity to engage in research. We need to continue engagement with the community physicians as well, and especially with the Duke physicians. Good communication with all the care teams that see these patients is going to be necessary so we can make sure that we're offering comprehensive care no matter where on campus these patients are being seen. And then, continued engagement. We've got this wonderful psychosocial support services through the TYAO program, through Bobby's coaches, and we just need to get more patients kind of funneled in there. We need to make sure we're not missing opportunities to that these patients can engage in these wonderful services. And then, of course, the further engagement with the Onco-fertility and all the eligible patients are being offered these important things that can be done. So.
All right, thank you, Dr. Wagner. So we have time for one more question. Sorry we didn't get to everyone. We will follow up with questions that didn't get answered. So here's the last question. What is the long-term goal for the I'm Not Done Yet Foundation and Duke Cancer Institute partnership? And so I would like to start to answer this question from the teen and young adult program side and then pass along to Dr. Maslow. So the collaboration between I'm Not Done Yet Foundation and DCI's Teen and Young Adult Oncology program is very valuable. The arena of teen and young adult oncology programming is very new. We're able to work together on our strategic plan to build a sustainable teen and young adult program that accelerates the development of resources supporting teens and young adults facing cancer. And this is highly visible, like Dr. Wagner mentioned, in our Onco-fertility program, which now features a 40-member physician-led steering committee crossing 7 disciplines. So we are able to package our program and share it with other cancer centers or other centers to assist them in quickly developing programming. Through Liz and Peter's advocacy, they are the boots on the ground, sharing the success and making connection. And as Dr. Maslow shared, peer connection is another area that has been elevated through the I'm Not Done Yet Foundation. So Dr. Maslow, I'll turn it over to you.
Sorry. It's really been just an extraordinary hour to hear about the different programs. And in terms of peer coaching, our goal is that no one going through cancer treatment, survivorship, or other chronic illness does it alone, and that we can have someone who's been through that walk with them and help them, become independent and able to, make their own decisions and be able to thrive. And I think that the goal of peer coaching, I think, meets that spirit, and certainly based on, honoring Bobby and also, what Liz and Peter have talked about, helping families be able to thrive in the context of chronic illness is our goal. And the collaboration, I think, has been really amazing with the peer coaching program, DCI and Indy.
All right, thank you, Dr. Maslow. And so with that, I'd like to thank, once again, thank you to all the panelists for such a comprehensive discussion around the importance of teen and young adult programming, specifically Onco-fertility and Bobby's coaches. Thank you also to the I'm Not Done Yet Foundation for your partnership that has truly helped to elevate and accelerate the services we provide to teen and young adults. I really feel like Bobby would be proud of how far we have come. So Peter and Liz, I will turn it to you for closing comments.
Well, first of all, thank you to the Duke crew who joined us this evening. Obviously, this is really, really important stuff, and I cannot thank all of you enough for taking the time this evening to share what we're up to with the I'm Not Done Yet passionate following, passionate contributors. I hope, from my perspective, just a few things. First of all, I hope that everybody that was able to join us tonight takes away the fact that this is real, this is important. There's a huge void. We heard the word new and in development and just starting, and you think about the fact that what we're up to is the realization that adolescent young adults have been left behind in not only their care, but in their overall psychosocial needs. And our goal, is to fill that. It's really, I mean, you think about this, you think about not only you diagnosed and you're about to go through the fight of your life, but the next sentence is you might be infertile, or you're diagnosed and you're getting ready to go through the fight of your life, and all you can think about is, who the heck am I going to talk to? Who is going to really understand this? And we saw it with Bobby. It was the hardest thing as a parent to really deal with, is understanding that your child, in this case, a young adult who's independent, who has the courage to face this, but you just hope that they have people to talk to, friends to help them get through this, because again, that level of independence is so important to them. So our goal with Duke is to build on what we started. In the case of Bobby's coaches, we view this as a petri dish of sorts, where we want to build a program, understand how it can be applied, understand the resources that are required, and grow it not only at Duke, but beyond Duke. If I had my way, I'd wave a magic wand and have this be a global program. Sounds lofty, but why not? And you think about the fact that again, you're diagnosed with a devastating disease, and now you've got to deal with infertility is part of a potential survivorship issue. And that's a real challenge. And I think that is another effort that is important, and we're passionate about it. And we need to make sure that no adolescent or young adult doesn't have the resources to deal with that in a comfortable and financially responsible way. So again, thank you everybody for joining us. We cannot thank you enough for your support, your help, your encouragement. Newsletters are on the way, so just pay attention. We've got more of these to come. We're excited about all the things we got going on. This is obviously a cornerstone of our efforts, but we got a lot more to talk about, and we will, this is the first of many of these that we hope to do to make sure that not only are we communicating well, but we share the progress we're making, as I mentioned earlier, as good stewards of the financial resources that you've placed in our hands. So on behalf of Liz, the Menges family, we cannot thank you again for joining us, and have a great evening. Thank you.